As Max Bach has said to us early on, or not himself personally, but his aide, well, there's a visceral reaction to single payer, right? Remember that? He was like, well, who's the visceral reaction from? You. Oh, it's the insurance lobbyists. Yes, they're the ones reacting. So we are fighting those interests. But so this is where the legislative fight stands, helping Senator Sanders by putting pressure on the senators from your states to demand a real policy debate on the merits, support for co-sponsorship of S703, that's the Sanders bill in the Senate, and a demand to enable states to do single payer by putting that in the Senate bill. So what you've got in your packet is a comparison first of the Senate Finance, Senate Health Committee, and H.R. 3962 passed by the House. And then I borrowed liberally, I did warn Dr. Young about this last night, I borrowed liberally from PNHP, as always, the best materials. They've got a great thing on the public option myths and facts. And then the League of Women Voters did a great comparison of single payer and public option, which I'll talk a little bit about. I put in some polling data just to remind us that, yes, the majority of the American people do support Medicare for all if there was political leadership to fight for it. We did a study on the economic stimulus impact of single payer, which as Wall Street bounces back and people lose their jobs, that economic report becomes even more important. And then there's a piece on frequently heard myths also from PNHP. And then a glossary of terms, which is pretty helpful actually. You know, when you get into these discussions, it's so jargon laden, right? And so that glossary can be very helpful. But let's talk a little bit about the House bill. As we know, the fundamental flaw of the House bill is that people are forced to buy private insurance either individually or by the employee. The employers have a mandate and individuals have a mandate. Forced to buy private insurance with a very limited public option. That public option is possibly going to enroll only 6 million people. So, you know, I don't know if it's that's exactly robust. I never could really figure out what robust meant, actually. But in any case, I think it's far from robust when you have that limited enrollment. But that's the essential scheme, using these insurance exchanges to then have people buy private insurance with some folks being able to get the public option. Two fundamental problems with that. Number one is that under this scheme, you only get as much health care as you can afford. And so this whole debate about affordable health care is revealing in the sense that, yes, health care is rationed by ability to pay, even under this reform proposal, because the amount of subsidies are tied to income, and the subsidies that you get are, once you are no longer qualified for Medicaid, right, at 150% of poverty, your out-of-pocket expenses can be quite high. So for example, we estimate that it could be 15 to 19% of your income spent on health care, right? Could be that high. If you look at some of the, at what they're talking about in terms of out-of-pocket expenses, at about 50,000, 50 to 60,000 family income, you could be looking at 10 to 11% of income for a premium and up to $9,000 in additional out-of-pocket costs before they're capped, right? That could be $14,000 for a family making $50,000 in income. $14,000. Mandated, right? So you're required to do this. Now, if you don't do this, right, and that's within the system, right? That's within the system. So you're not exempted from the mandate if you're spending at that level, right? Only when your expenses for premiums exceed 12.5% of income are you exempted from the mandate on a hardship basis, right? So 10, 11% of income, you're still subject to the mandate. So number one, and then within that system, within the exchange, there are tiered plans, A, B, C, based upon the premium tied to benefits, right? So if you spend more on premium, we'll get more benefits, but it is rationed by, again, ability to pay. Because everyone is required to buy the basic plan, and then you can spend more for the upper tiers, right? So the more money you have, the better plan you're going to get. And then there's the premium plus plan, D, right? So for those who are really like private insurance, you can spend a lot of money, right, and get a benefit plan. So that's how it's rationed by ability, essentially by ability to pay. If you spend more of your own income under the mandate, you are going to get a better private insurance plan. Secondly, the fundamental problem, of course, is that there is really no change in how the insurance companies operate. Yes, they have to provide coverage to people with pre-existing conditions, right? Within the exchange, they have to do that. But there are no restrictions on how much they charge, right? And there's no change in how they process claims. They can't rescind policies necessarily, right? Once you have a claim put in, but they can still deny claims. So you have a situation where you're going to be required to pay all this income, but fundamentally you don't have a guarantee of health care. So you get all the health care you can afford, but all the insurance you can afford, but no guarantee of health care. That's the essential problem with the structure of the plan. And that's because they rely upon private insurance, as we know. You'll hear a lot about the medical loss ratio. Do we know what that is? How much the insurance companies have to spend on, oh my God, medical care. Oh, that's right, it's health insurance. They got to spend it on medical care. All right. So they decided that they have to spend 85 cents of every dollar on healthcare, but then they don't regulate the rates, the premiums. So, well, gee, if I'm making 30% now, I'll just raise my rate so that 15% will equal my profits that I'm making now. I mean, it's very straightforward, right? And the only check that they have is based on a theory of market competition. So from our perspective, it's a market-based reform, right, that relies upon an untested theory to rein in costs that no other country in the world has ever tried or would try, because they're not wedded to private insurance. So when you hear about this, it's like the Swiss system. Well, the Swiss system, first of all, is nonprofit. Secondly, they don't underwrite. It's a basic benefit package that's offered to everybody, and the plans have to provide it, and they have to provide that coverage. They can't deny claims. They're essentially administrators, right? They are not underwriters. This is a plan that preserves the underwriting function because it still allows denials of claim and different tiers of coverage. So when you hear about that medical loss ratio, in the context of no premium regulation, it simply doesn't matter. So, and then of course, this is not a universal healthcare system, right? 96% is the best it's going to achieve in the House side. So, and that's probably, now remember, most of these provisions go into effect in 2013, right? So I don't know exactly where the political geniuses in the White House thought up this one, right? So they're going to get hammered for 4 years about how people are going to have to spend 15 grand to buy private health insurance. And at the same time, premium is going to keep going up. Some modest amount of money is going to be devoted to people who still can't get insured because of their pre-existing condition. They do put some money in to cover those people in the interim. And they get to be hammered for 4 years until any of this really, until the bulk of it goes into effect.